another question in the chat that was asking about biomarker testing for early stage non-small cell lung cancer. And is it something that is routinely done now, given the recent data that has come out with the use of targeted therapy in early stage disease? So I guess just hearing from people and at their institutions, what happens for patients that have early stage non-small cell lung cancer in terms of biomarker testing?
Yeah, so I think at both. So I trained at Mayo, and we used to do, even for early stage, do biomarker testing. Now I'm transitioning to UAB. I think here also the practice is that, and as you mentioned, Dr. Higgins, as more and more data come out for the perioperative immunotherapy setting, which some of which Dr. Rose touched upon as well. I think it's important to test because some of these studies did exclude EGFR and ALK mutated disease, so may not be directly translatable to that. So definitely testing, pretty much all of our patients, early stage, advanced stage, except for possibly just stage 1, with the biomarker testing.
Yeah, and I'll say it's absolutely critical, but it's an even more challenging environment because you're oftentimes dealing with a smaller biopsy sample. Perhaps a pulmonologist went in and did an FNA, a fine needle aspiration. So there's limited tissue. You want to know the histology, make sure it's not a small cell or some other different type of more aggressive lung cancer. And then, playing the waiting game and someone who you want to then go on to surgery, do you send that out for a full NGS and risk that there's not enough tissue? Do you do a more limited panel? I know at our institution, we're starting to actually kind of revert a little bit and do some more limited panel testing to some of the more, actionable kind of limited alterations, so we can at least get those answers quickly, so we can try to make, a decision, tumor-informed decision that still allows for a curative intent treatment approach.
I mean, I'm just going to add that, yeah, I mean, I think as patients, patient advocates, family members, it's and physicians and teams, it's on all of us to really push hard to make sure that the testing is done for early stage disease. It's relevant for disease that's resectable. I imagine very soon it's going to be relevant for patients who receive SBRT for early stage disease, for instance, because there may be some SBRT adjuvant immunotherapy trials that become mainstream. And if you have a targetable mutation, it may not be ideal for you to receive immunotherapy in the adjuvant setting. And so there are a lot of reasons why, for all indications, early stage disease, we should really push to get some form of testing up front.
And then what do you guys think is happening in the community setting? I know probably at your institutions, molecular testing is happening on all non-small cell lung cancer patients, but bridging the gap and making, we're having consistent processes for patients that are treated everywhere is, I think, a really important point. And I just wanted to ask about what your experience is with patients that are perhaps coming in from having been consulted on in a community setting and what you're seeing.
Yeah, I mean, I would say it's been variable, but I think it's getting more and more to the point that we are seeing more and more patients being tested in early stage setting, again, because some of the pivotal trials for perioperative immunotherapy did sort of exclude certain patient or certain subgroups of genomic altered patient, non-small cell lung cancer patients. I think the other important point we have to mention is, it's important to test, because if we test and we identify, then we can offer clinical trials. I mean, Dr. Rose mentioned a few in the perioperative space with, tyrosine kinase inhibitors. So again, I think testing, there also becomes important to be able to offer these options for clinical trials.